Once the patient has been properly positioned, the surgeon locates the tendons by applying pressure to the antero-internal face of the tibia. A permanent ink marker is used to trace the incision site directly above the tendons. A 2 cm vertical incision is made following the ink mark previously traced, 2 cm from the anterior tibial tubercle. The subcutaneous tissue is dissected by avoiding the soft tissues as much as possible. The superficial aponeurosis is carefully cleaned with a gauze sponge. The tendons can now be clearly identified underneath the superficial aponeurosis. A horizontal incision is made above the gracilis with a number 15 surgical scalpel blade. The aponeurosis is then grasped with forceps as proximally as possible. At this point, the 2 tendons are clearly visible on the internal face of the aponeurosis, the gracilis displaying typical undulations on its surface. The gracilis is then seized with a probe and isolated on the tendon hook. The tendons are divided either with Metzenbaum scissors or with the blunt end of the probe, which is specifically adapted. The semitendinosus can then be grasped with the probe hook and the gracilis isolated by placing it under the retractor. Then, by alternately using the probe and hook, the aponeurotic expansions are seized one by one. It is very common to see this pale-colored extension on the inferior face of the tendon, which typically indicates the presence of an expansion. Finally, by palpating the inferior part of the tendon as proximally as possible, the surgeon checks that no aponeurotic expansions remain. The half-opened Linvatec stripper can now be positioned and closed over the tendon. The tendon is now harvested by making sure that there is no hard resistance, which could be indicative of the persistent presence of expansions. The tendon is extracted by leaving the tibial attachment intact. Expansions are selected one by one with Metzenbaum scissors, after which the semitendinosus tibial attachment is cut off with a scalpel by leaving the gracilis attachment intact. Once the operation is completed, the incisions are closed by overlock suturing with Asufil 3.0 absorbable thread.